Good afternoon, everyone. I'm Beth Stroll with the Technical Assistance Network for Children's Behavioral Health, and I'd like to welcome you to the System of Care Leadership Learning Community meeting today. It's fantastic to see such great participation, and I think it reflects how important the topic is of crisis response services and how vital to your systems of care. Denise Sulzbach and I co-facilitate this learning community, and it is a learning community for system of care leaders that we hold on a monthly basis, and we designed this to support system of care leaders in all roles, SAMHSA grantees, leaders in various content areas, and other leaders in states, communities, tribes, and territories that may not have federal funding at all. And actually, it's geared for any in leadership roles in system of care implementation, expansion, and sustainability. We try to select topics that either you've recommended or that are that we feel are important to your work, and we do try to make this interactive, and we do recommend that you encourage, or that we encourage you to put your questions, comments, insights in the chat box throughout the session. We have incorporated time for questions and answers at the end, and we'll make sure that any of the questions that you enter in the chat box will be addressed. Before we get started, I'd like to mention a couple of things. First, the next Learning Community meeting will be February 21st, also 2:30 to 4 Eastern Time. That session will focus on current issues in working with family and youth organizations. We'll look beyond the basics of family and youth engagement and leadership and get into what family and youth-run organizations bring to this, the challenges that you may face in working with them and working together, and then strategies for addressing those challenges. So we hope you'll put that on your calendar and join us then. Also, I'd like to mention that at the end of the session, an evaluation survey will pop up that will give us feedback on how you felt about the usefulness and quality of the learning community session. We do take your feedback very seriously and use it to improve these learning communities, so thank you in advance for completing the survey. Today's topic is considerations for system of care leaders for implementing a continuum of crisis services, and we are very fortunate to have a great group of presenters who are experts in this area. Diana Simons and Liz Manley are both from the TA network. Among many other roles, Diana coordinates the training that we offer on mobile response and stabilization services, and we're delighted that Liz Manley recently joined the TA network from New Jersey, where she was responsible for the statewide system of care, including, of course, its statewide mobile response system. Tim is from Connecticut, and he oversees the state system of care efforts there and its crisis system as well. So I'll now turn this over to Diana and Liz, who will start with a context and identify leadership considerations, and that will be followed by detailed examples from both New Jersey, from Liz Manley, and Tim Marshall from Connecticut. So Diana and Liz, I'll turn this over to you now.
Thank you, Beth. Liz, I'll take it first. I've got a couple of slides, and then I'm going to turn it over to you. I'm really excited to see some of the names of folks I work with on a regular basis participating in this call, and several people that have already come through the mobile response and stabilization curriculum. And I'm pleased to be here today to talk to you about it a little bit. Almost 5 years ago, the Centers for Medicare and Medicaid Services and SAMHSA issued a joint bulletin on the coverage of behavioral health services for children, youth, and young adults with significant mental health conditions. And in that bulletin, they identified several services and supports that enable kids with complex mental health needs to live in their own community. The joint bulletin noted that implementation of these home and community-based services for this population made a significant improvement in the quality of life for these children, youth, and families, and evidence backs that these services are not only clinically effective, but they're also cost-effective. The bulletin validates efforts related to mobile crisis. They call it mobile crisis response and stabilization and other services, and it guides states in ways that they might provide these services under Medicaid. So about 2 years ago, in April of 2016, we launched the Mobile Response and Stabilization Services curriculum, and we consciously changed from crisis to mobile response and stabilization, because we believe that intervening earlier, these next generation models that you're going to hear about from Tim and from Liz, intervene earlier and define crisis by what the family defines as crisis. So we're trying to change the language and the semantics a little bit. So mobile crisis response and stabilization, mobile response and stabilization, we're talking about similar things. We just completed our 4th meeting in December of the Mobile Response and Stabilization Services peer meeting. New Jersey has been very gracious to host us all 4 meetings that we've had over the last 2 years. And we've had 20 states and about 25 teams come through thus far. We are really looking forward to our next meeting in the spring, as it's going to also include an alumni component, because now we have a girth of folks that have been through and have some lessons learned and some feedback, and we're excited to expand that a little bit this time. So the innovative models of mobile response and stabilization services, like the 2 you're going to hear about, New Jersey's and Connecticut's, go beyond traditional crisis intervention. They include home and community-based stabilization and case management services, on-site face-to-face and therapeutic response, assessment, crisis intervention and stabilization, as well as psychiatric consultation, psychopharmacology, and referrals and linkages to other services and support as well. And they're of pretty significant value. These next generation models are really significant and valuable to systems of care for several reasons. And I tried to get really decorative with these slides, but we have to vet them with SAMHSA, so they're a little bit stock photo-y, so apologies for that. From a fiscal perspective, mobile response and stabilization services, the next generation version of them, are valuable in diverting children, youth, and young adults from higher, more expensive levels of care. And because they can be used across populations and financed through a variety of funding streams, they are flexible, and they can serve a lot of kids, and they can serve a lot of the needs of systems that are involved with kids, including child welfare and juvenile justice and mental health and schools. They play an important role in preventing emergency room use and psych hospitalizations, but also residential treatment and placement disruptions among children, youth, and young adults experiencing behavioral health crisis, contributing to improved cost and quality outcomes. One of my favorite examples, and Liz will probably expound, and I'm stealing it again, Liz, I'm sorry, is from New Jersey, because New Jersey Child Welfare uses mobile response and stabilization services for children ages 4 and up who are removed from home to foster care, and their outcomes include seeing no placement disruptions due to behavior when mobile response and stabilization services are used, and they're involved. From a quality of life perspective, mobile response and stabilization services improve that for children, youth, and young adults and their families. They not only, as I said, get to define what a crisis is, but are also allowed to stay in the least restrictive, safe environment in their homes and in their communities, both for the assessment and for the follow-up component. And mobile response and stabilization services are valuable to schools and to the community as a resource in both educating people and also in de-escalating crisis in these areas. They're also resources to systems of care. So they provide access points for linkage and referral to services and support, both formal and informal, like care management entities, for instance, or youth and family organizations. And they're also assets to service providers themselves. They really do act like a bridge to and from system of care service arrays, and they're also an essential tool in a comprehensive system of care. So I would encourage you to ask a lot of questions, and I would also encourage you to reach out after this learning community if you have additional questions for me or for any of the faculty of the Mobile Response Stabilization curriculum. We have a resource library, and we can send you information. We can put you in touch. I would also put a pitch in for you to look for the next application for the Mobile Response and Stabilization Services peer meeting in, I think it might be in May this year or in April. And to consider sending a team to that if you haven't already. So with that, Liz, I'm going to hand it off to you.
Thank you. So I am Liz Manley. As Beth has clearly articulated, I've recently left the physician of Assistant Commissioner in New Jersey's Department of Children and Families, and am new to the TA network, so I'm happy to be here. And happy to talk about mobile response and stabilization and the role of mobile within the context of continuum care, and why I think that as a service, it's one of the really important services for systems transformation. So mobile response and stabilization, which has been the service name in New Jersey for quite a long time, has been an incredibly important service in order to build a continuum within the context of New Jersey system of care. And slide. Can't move the slide. So, examples of early use in mobile. Let me just step back for a second and say that mobile response has been a service that's been around for a very long time. In New Jersey, it's been around for about 17 years, and its early use was really totally about diversion from emergency use. And it's an incredibly important role for mobile to keep youth out of emergency centers, but it also can, when it's utilized properly, more expansively, it can actually step in when youth are beginning to experience some type of crisis. And it cuts down the amount of time it takes for families to be able to recognize that something's going on for a child, and delays the amount of trauma that a child might experience. So I will talk in a minute about the mobile response work within the context of New Jersey's child welfare system, which has been pretty much transformational in terms of keeping kids in foster care. So mobile response can be used at a time by caregivers can reach out when they're beginning to recognize that a youth is demonstrating or is beginning to demonstrate an escalation of behavior or a change in behavior. So in other words, if youth begins to really dramatically change, their grades go down, they're struggling at school when they didn't before, they can't get off the sofa, those kind of symptoms that parents begin to recognize early and recognize that a child might be struggling, or a pediatrician recognizes, or a school recognizes that something that is different, it can actually decrease the amount of time that youth gets connected to supports and services. And because mobile response has the capacity to be able to engage in community supports, not all children who utilize mobile response actually need a therapeutic intervention at the end of the transition from mobile response and stabilization, but they absolutely all need a connection to they need a connection to community, to activities within the context of school districts, and a better understanding of what's happening for both the youth and family, as well as their partners like pediatricians and teachers. So some of the leadership challenges I think states and folks have experienced in terms of building on mobile response, or building mobile response to begin with, is the issue of setting the vision and what you're trying to accomplish by bringing in a service like mobile. I think that the setting the vision for the community and for all partners who really need to understand the direction that the system is moving in is incredibly important. And then writing that vision down in a way that folks can actually go back to when they get off course or moving in a direction that's a little bit differently. It helps in bringing aboard all of the partners that are necessary in order to make systems change, because the building of mobile response and stabilization, as smart a service as it is, and as much as you can document its success in other places, becomes a challenge for communities who are used to utilizing services in a particular way. There are budget challenges in terms of how do you start up mobile response and stabilization, and how are you going to pay for the service in the beginning. But the return on investment on utilizing the service like mobile is just so incredibly powerful for youth and families as well as communities. And it also is a less expensive service than a youth going into or having an experience in an emergency room, as an example. It's incredibly important to be able to communicate new changes and talk about why those changes are important, and to utilize national models around why. That's why the joint letter from SAMHSA and CMS is an incredibly important tool in terms of making these changes and identifying in your community early adapters who understand that early intervention makes a big difference for youth. And then there's the workforce development issues that become really a challenge for all of us in this work, but are incredibly important to have your early adapters out in the community helping even in terms of the workforce development and training concerns and challenges. So the big, as you're making systems changes, I think it's having some leadership strategies that are going to help get you through some of the difficult times is important, like understanding how and when to communicate the vision of where you're going and to go back to that vision whenever necessary when folks are veering off track. In New Jersey, the Children's System of Care was built in 2000 and really 2001. It was the beginning of a statewide rollout. And during that period of time, there was a concept paper that was published that really assisted the state leaders at the time to be able to articulate the vision of where they wanted the Children's System of Care to go and why it was important to get there. And the impact of youth and families was clearly articulated within the context of the concept paper, which is still an active tool that's utilized today whenever the system begins to bring in new populations or to veer off track, or it looks like it's veering off track. The concept paper was so incredibly important that it's still published on the Department of Children and Families website even today. And it helps really re-energize the champions in this work by having that document that they can walk around with, that they can go to and say, this is what we really want to accomplish for our youth and families. It helps in our transparency. It helped in sort of setting the course of where things were going to go. The other important part in terms of making these transformational changes, like bringing in mobile response and stabilization into communities, is it allows the opportunity for our youth and families to get support early, and then for us to track that data and track the changes to the local community what it means, and to build on those successes as we move forward. So another really important, I think, probably the most important leadership strategy that I utilized when I was in New Jersey was to be flexible and acknowledge it, that I didn't know it all. In fact, we still, every day are learning, but at the same time, we didn't know whether or not things were going to work at the moment that we were doing them. But we had to believe they were, and we were going to create feedback loops in order for us to understand this work moving forward. The important considerations are understanding the impact in the current system, so really understanding how bringing something new in is going to impact on what already exists. And that's both important in terms of the impact of the providers and the partners who are currently doing that work, but also the impact on families and how they'll move and gravitate to the new work as you move forward. And really embracing a parent and youth culture, and not only in the design of the services and supports, but in ensuring that there's a really clear feedback loop that parents and both youth and young adults as well as children can provide some feedback in their own experiences around the supports and services and what worked and didn't work. It's also important to build a culture, a provider culture of change, and to advocate and a culture for the advocates to be able to share their concerns as things move forward. Data is an incredibly important part of the work, collecting it wherever you are right now in terms of data, understanding your baseline of where you are, and also understanding what data points are important in the steps forward, and then being able to tell the story of the changes in the data in real time. You have the challenge of quality within transitions. Quality is always a challenge, and the issue of privacy really needs to be addressed in a way that is thoughtful and clear. So New Jersey, I talked a little bit about New Jersey already, but we'll continue this conversation in terms of some of the impacts in New Jersey over time. The Children's System of Care was started in New Jersey in 2001, started with the concept paper that I've already spoken about. And it started because there was an over-dependency on high-intensity services like residential and inpatient hospitalizations in New Jersey. We're spending a lot of money on interventions that we really weren't getting a lot of great outcomes from. And we had low-intensity services like outpatient, which was not as readily available as we really needed it to be, and it wasn't as effective as we had hoped it would be. And so we worked on really building a third continuum, and that is the intensive in-home supports and services, and to build out some of the lower intensity services within the context of the community in terms of the work. And mobile response really is and can be a low intensity service and an intensive and community service in some respects all the time. And the reason that is because mobile can be used when families believe that something is going on, and it is their definition of crisis that becomes incredibly important in terms of your work. If a parent picks up the phone and calls the public mental health system and says, I have an issue and a challenge and I need some help, then the public mental health system in New Jersey has made that commitment to respond and to say that we're coming, and when we come, we're going to provide some support to both you and to your child. Incredibly important part of the conversation. Another really important, really transformational change in New Jersey was just the use of language itself. The Children's System of Care in New Jersey does not ever use the word client, cases, or placement. These are not the words of the Children's System of Care. The words of the Children's System of Care include children, youth, and young adults. We talk about parents and caregivers. We talk about treatment and not placement because there's a difference between treatment and treatment as an intervention as well as opposed to placement. It is the job of the Children's System of Care in New Jersey to engage and to engage all individuals, to engage our youth, our families, our advocates, our providers, our partners in the work. Our job is not to talk about how folks are not motivated. That is not our job. The job in New Jersey is really about ensuring that we work hard to motivate and engage all that are partnering with us in this work. The work of transition is incredibly important. The Children's System of Care does not close or terminate individuals. We transition the work away from the family's home. Actually, the professionals step out of the family's home as the families actually utilize the tools that have been built during the work of the Children's System of Care. In New Jersey, they talk very much about youth being missing, not about running away. And family time is the work of the Children's System of Care. We don't provide home visits. Our children just go home. Language is important. So some of the key system components within the Children's System of Care is a single point of access. It's called the Contracted Systems Administrator. The contract is currently held by Perform Care. And Perform Care is available 24 hours a day, 7 days a week, 365 days a year to answer the phone and to talk to parents and connect parents and caregivers and youth and young adults to supports and services within the context of their own communities. There are local organizations called care management organizations. There are 15 of them across the state of New Jersey. They are the wraparound facilitator, and they have only two responsibilities: to provide care management and community resource development. And they are considered the local leaders of the system of care in each of the communities. And there's mobile response and stabilization. Mobile is a service that is an incredibly important service that has led the changes within the Children's System of Care. They led the way when, in 2012, children with intellectual and developmental disabilities were integrated into the Children's System of Care. Mobile response and stabilization went out and met with youth who were nonverbal, built and utilized supports for those individuals, and told the Children's System of Care, helped us figure out what services and supports would be necessary for us to be effective in keeping our youth with intellectual and developmental disabilities at home. It was a big learning curve for all of us, but we really worked together to do that. And mobile led the way, as they had led the way in the transformational changes in New Jersey. And then we have independent family support organizations that actually allow us to be able to engage both our youth and our families, and they are the leaders in terms of policy changes, in terms of what services and support should look like, and in providing peer support to all our partners. Some other key components in New Jersey, we do have intensive and community support services that are, there's the clinical work that goes into the home. They connect with mobile response. Mobile can put licensed clinicians within the context of homes whenever that's necessary, and they deem it necessary. So can care management organizations. We have a full continuum of out-of-home supports and services for youth, and mobile cannot connect to out-of-home or the out-of-home continuum. They connect with care management, who connects to out-of-home. Mobile is really the front runner for the system in terms of being able to engage early, to help us identify early what youth are going to need more intensive services and supports, and what youth really need to just be connected to community supports. We have a full continuum of supports and services for youth with intellectual and developmental disabilities. It has made a huge difference in being able to keep youth at home in New Jersey. There's been a 900% increase in the utilization of in-home supports for youth with intellectual and developmental disabilities since 2012. We're pretty proud of that. And we have a full continuum of services for youth with substance use, which is a pretty complicated component and requires some expertise in order to engage youth who are currently using. And then we have a full continuum of your traditional supports and services. But the need for outpatient services has shifted dramatically since the beginning of the children's system of care, because the role of mobile response is just to connect, and to connect to the things that are important to the youth and important to the family, and to ensure that that youth has a support system in place, not necessarily that that youth has treatment in place. Treatment is really the step when the youth is ready to engage in treatment, which is an incredibly important component of the work of mobile. One of the big lessons that we have learned here in New Jersey. So New Jersey Mobile Response mission and goal really is about just keeping our youth safe and at home, keeping them in their own homes and in their own communities. And they've been really amazing at being able to do that. Mobile helps the parent define what the crisis is and why they picked up the phone that day to call the public mental health system to ask for help. Like, what was it that caused you today to call? Was there something specific, or has this been going on for a while? Mobile's job is to help the system and help the parent and the youth themselves understand why that call was made that day, and to help understand why the balance of that child is really, and the sense within the family, is disrupted, and what that disruption is about. Is the disruption about something that's gone on at school? Was there something that happened with bullying? And as an example, for a youth who has been removed from their home because of concerns around abuse and neglect, the question is really for that system is, well, we know why that child's balance has been disrupted. Now the question for us is, what do we do about it, and how do we help that youth, and how do we help the resource folks or the foster family who's going to take care of that youth understand the level of disruption that's happening for that youth, and how do we get them back on track and as quickly as possible. So the goal of mobile response is really to help define all of that. But it's not the system's definition of that, but help the family and the youth themselves be able to define that for themselves, so that we can begin to put things back on track. The mobile response is open to all youth and young adults under the age of 18, anyone from 18 to 21 who calls themselves and asks for the service. Any parent or caregiver across the state of New Jersey can call, but consent is necessary for the service. And it's really about the escalating emotional, behavioral needs of the youth that are important and drive the work. And the family's definition of crisis is incredibly important. Program eligibility, we do have a clinical criteria. There are two components of mobile response in New Jersey. There's a 72-hour component where during that 72-hour we're really helping to define the crisis and really think about what some supports and services could be for that particular youth. And then there is stabilization, which is up to 8 weeks of stabilization, which is really the case management component of the work and the connection to community supports, including the really important folks like the pediatrician as well as the school, to ensure that we have some sense of what it is that what needs to happen for a sustainable plan. It's also important to know that we have special populations within New Jersey, as I think most folks do, in terms of youth with intellectual and developmental disabilities, substance use, but also youth who might enter through the court system or through what we call a family crisis intervention unit. We have them merged in New Jersey, which has really been helpful. The family crisis intervention units are actually the non-voluntary component of the system. Most families, in fact, the majority of families who touch on any of our systems come in voluntarily these days, and if they come in from an involuntary position, we actually move them pretty quickly to voluntary when they recognize the services and supports are available for them. And it's open to every family in New Jersey from tip to toe in every community. Program access, so there's a single point of access. I talked about them, that's Perform Care. There's a clinical triage component that happens really on the phone with Perform Care, as Perform Care is trying to figure out what they're going to connect that youth and family to, because they have the capacity to connect to other supports and services outside of mobile response. But any family who asks for mobile gets mobile, and any family that Perform Care believes could utilize the supports immediately gets mobile as well. There is verbal consent, which is incredibly important, but also a warm line handoff to the local mobile response unit. And what's important with that warm line handoff is also there's the building of or the starting of the electronic record. New Jersey has an electronic record that's utilized with all families, all youth and families who are engaged in the children's system of care, and for all providers. And that parent who called in and provided information, that information is actually available to the mobile response worker before they ever leave their office, which is an incredibly important component of the work. So the program structure, it's 24/7. 24/7. The mobile response folks have to be either within an hour any place in the state of New Jersey, and they can be any place in the state of New Jersey. We work with our providers to be able to figure out where they're going to be located to ensure that they can get to all parts of the communities that they serve within an hour. There's a lot of thought that goes behind that. There's the 72-hour intervention that I spoke about. There's also a provider network. So the way the New Jersey Children's System of Care is designed, the Children's System of Care itself, the state entity that sits within the Department of Children and Families, manages the full provider pool of all providers that touch with our families. So that includes the mobile response contracts themselves, but it also includes all the folks that mobile response connect to. That includes all Medicaid providers for in-home support services, for intellectual and developmental disabilities, for substance use. It's a very large provider network that grows as the needs of youth and families grows as well. So some of our lessons learned, and I think they're incredibly important lessons that we have learned. To set, document, and communicate the vision, incredibly important. It helped keep us on track whenever we sort of veer off and try to think that one of our partners isn't as important as the architects believed that they were. As an example, one of the lessons learned in New Jersey was the value of community partners and the feedback loop to community partners. Under some leadership within New Jersey, they tried to minimize that role, and the system did not function as well as it needed to during that time. You need to create a feedback loop with communities, and that feedback loop needs to be both ways. It needs to be a place that you communicate the priorities and policies that are driving, but also a place to be able to hear from communities how the rollout's going and what it looks like. I imagine most of you experienced what I experienced when I was in New Jersey, and that is that the 21 counties that we have and the 9 million people in New Jersey are all a little bit different. All 21 counties operate differently. They have different strengths. They have different traffic patterns. We have rural. We have urban. We have communities that are less than a mile that will take an hour to get from one place to the other, and we have communities that are blocked off in terms of not only traffic but in terms of resources. And so it's incredibly important to know all of the communities that you serve. We use data to make changes and to tell the story and to make real-time changes. The data should help you be more nimble, not less, and help you make decisions that are in the best interest of the populations that you serve. We communicate early and often and try to do as much of that in writing as possible, and also to be able to see and communicate directly in any way possible. The more avenues to communicate what's happening and the changes, the better off you are. I want to tell the story, I think, is an incredibly important story of how you let people know that the system exists, because partners don't remember until they need to remember. And so you need to have lots of different ways of being able to ensure that that happens. As an example, one of my partners told the story about how he was working with a vice principal of the local school when he was talking about performed care and talking about the work of the Children's System of Care. The partner, the vice principal said, "How come I've never heard of you before? I don't understand why this is the first time I'm hearing about you." And my partner, Victor, basically said, "Liz, I was standing there staring at him, and right behind him on his bulletin board that he would stare on every day was a flyer from Performed Care with a Performed Care number." So that story helped me remember that I had to communicate early and often and continue to communicate the same message over and over and over again in order for folks to be really engaged. Identify early adapters and use them, help them spread the message, and help them, provide them the supports they need in order for them to be successful. The crisis defined by the youth and family, I've already talked about that, and mobile response can work with all populations. In New Jersey, we demonstrated that by making the service available to any family that calls 24 hours a day, 7 days a week, with no rule-outs at all. We use community partners to assist in making connections to community supports. Not all youth benefit from treatment. Not all are ready, and so we have to provide them the supports and build sustainability plans that can help our youth be ready when they're ready. And we invested early in a single point of access. This was one of the smartest tools in our toolbox. It allowed for all of the infrastructure changes that happened later and got us ready to deal with the major storm of Superstorm Sandy in 2012. For more information, you're more than welcome to reach out to New Jersey's Children's System of Care, and there's a ton of information on the Performed Care website that I encourage you to take a look at. And now, I'm going to hand off to...
Actually, I'm going to jump in, Liz. This is Denise, and ask you to just hit a couple questions that came in while you were presenting. The first one is from Kayleen in Wyoming, and she is wondering if you could advise as to how New Jersey's MRSS system interacts with your high-fidelity wraparound.
Absolutely. That's a great question. So our high-fidelity wrap really sits within the context of care management organizations, and the way the system envisioned mobile response is that mobile is sort of the front door for a lot of families, not for all families, but for a good portion of families. Maybe about 45% of our youth come in through mobile response and stabilization. And our mobile units actually identify youth who really could benefit from high-fidelity wrap. So that's how they sort of connect to that. There are other connectors, so you don't have to come in through mobile response to connect. But what happens is mobile will go out, meet with the youth and family, recognize that some of the challenges may require more time, and they electronically put in a request for that youth to be connected to care management. Care management are the providers who provide high-fidelity wrap in New Jersey.
Great. Thank you, Liz. And Kayleen, Tim is going to address that question from Connecticut's perspective as well in a few minutes. Before we hand it off to Tim, there's just one more question that's New Jersey specific, and that's coming from Jim. He's wondering what assessment tool New Jersey uses.
Sure, absolutely. Great question. So New Jersey uses the CANs for all youth who are engaged in the system of care every 90 days. It is adapted for youth who come in and are utilizing mobile response and stabilization. We call it a CAT, or a crisis assessment tool, and that CAT is completed at the time that the youth is engaged with mobile response and stabilization. There are other tools that are used depending on the population. However, the common assessment tool is the CAN.
Great. Thank you, Liz.
Yeah.
And John, we'll address your question about single point of access at the end, so both Tim and Liz had the opportunity to respond to that one. Okay, Tim, the floor is all yours. Thanks, Liz.
Great. Good afternoon, everybody. So just to jump in a little bit and a little bit of background about Connecticut. So like New Jersey, Connecticut is a fairly mature system. We went to a system of care approach for children's behavioral health in 1999, and at that point, we already had a mobile crisis for about 7 years at that point. So we've had a number of iterations. So what you're going to hear about is a kind of a mature mobile crisis program, and so some of these are based off of, the enhancements over the years have been based off of lessons learned. But the number one thing that really drove us to where we are today we were, like many areas of the country, seeing high rates of ED use by children with behavioral health issues. And in particular, we had a couple of years where lots of kids got stuck. So mobile crisis response was really instrumental in helping with that. We had high rates of inpatient and residential treatment. We had a shift, as I said, in the late 90s, 1999, we moved to a system of care approach, which really started the first enhancement to mobile crisis, and then in 2008 we developed what we have today. What we learned was we actually had a contract that disincentivized mobility. So what we find is when you give people an opportunity to triage, they'll triage out a lot of calls that are really crisis, that really probably should have a face-to-face. So our mobility rates were low because providers were not incentivized to go out. We had lots of dissatisfaction, and we saw continued high rates of ED use. So we really embarked on a full model redesign, and what you see now is fully implemented for the last 7 or 8 years. So what is mobile crisis in Connecticut? We still are referred to it occasionally here as EMPS, the Emergency Mobile Psychiatric Services, but we really have been working on a name change. But because it had been so inground in the vocabulary, we still sometimes refer to it as that, but we really are trying hard to just refer to it as mobile crisis. So it is a team of mental health professionals, and they're master's trained responders. Each site has a director, and they have psychiatric consultation with child and adolescent psychiatrists or APRNs who are trained. And a few of our private providers have family partners or peer support partners that could go out following stabilization. Our system is funded both by DCF grant, state dollars, general fund dollars, as well as Medicaid reimbursement, and a number of commercial insurers also have now begun to reimburse more readily. Anyone in Connecticut can call on behalf of a child in crisis, and again, like New Jersey, our crisis is defined by the family. We do not triage any crisis out. So a family's calling a stranger to find out about how to help their child. We think that's a crisis in and of itself. So we strongly encourage that to be used. And again, for any child 18 or under, and if the child is still in school, the providers can respond to the school if the child is 19 years old. If the child is still in high school and over 19 years old, we still respond to the school, but the primary client, so to speak, at that moment is really the school, just because in Connecticut our system is bifurcated, and the adult system kicks in for 19 and over. The service is available to anyone in the state of Connecticut, regardless of insurance, no insurance, whatever the status. All of our responses are covered. And the only areas that we exclude is there any of the locked settings with the inpatient hospitals, subacute units, or residential treatment centers. We have 6 primary contractors, and they have a total of 14 sites. That represents 170 master's level full-time trained crisis clinicians, and additionally, every one of our 6 providers uses quite a bit a number of part-time or per diem employees, particularly when volume is high. There are really 3 main components. There's the provider and the response network at the local level. There's the statewide call center as the second, and the third is the performance improvement center. The statewide call center, we have a single number. We use our information and referral 211 in our system. Then the caller is instructed to hit 1 again and 1 again, and those 2 additional prompts break through the informational referral, and they get access to a live body, generally within 5 or 6 rings. And so we control every call through a single number. This call center does a very brief triage, really around assessing is there a need for an ambulance, is there an accident or blood or weapons, or is it an ambulance or police, and if it's not, then it's generally going to be rated as a mobile response, and we'll get the next response, and we'll send a team immediately. The third component is a performance improvement center, and they help us with data collection, data analysis and reporting, and a lot of quality improvement. And you'll see some of that data and quality improvement in a little bit. We have a standardized training curriculum for all of the clinicians and the 6 providers. We use standardized practice, and we have a single statewide crisis assessment tool that we developed in Connecticut ourselves with all the providers in partnership with them. And then we do additional reports as necessary. So we are 24/7, but we actually only go face-to-face mobile from the hours of 6 a.m. to 10 p.m. Monday through Friday, and 1 p.m. and 10 p.m. Saturday, Sunday, and holidays. We find that that really does get to a tremendous number of the crisis and that warrant that face-to-face. Hours outside of that range, people who call are then offered the very first next appointment. So if they call after 10 p.m., they'll get a response first thing 6 a.m. in the morning, or what time they request it, so that they automatically will have a face-to-face follow-up if they're calling during non-mobile hours. The providers are required, and we handle multiple calls at any time, and in particular during high peak times. What are the key provider performance benchmarks? Is they have to be able to have reach a volume per their population census. So we monitor how much do they penetrate per 1,000, how many calls they receive. They're required to be mobile 9 out of 10 times. They have to. That means that they must go face to face. There's that 10% window that allows them a little bit of flexibility. And they have to respond quickly. They must be face-to-face within 45 minutes or less 80% of the time. Last year, our medium response was 27 minutes, so we're really proud of that, that on average you're going to get a face-to-face assessment in about 30 minutes during mobile hours. We really felt like we wanted to be clear that we are buying a face-to-face assessment. One of the lessons learned that we had was the more time that the caller spends on the phone with the initial call, the less likely they'll go face-to-face when we were doing triage. So what we did is we just eliminated triage altogether, and again, the crisis, we said, is defined by the caller, and what we reiterated with all of our providers is that what we are purchasing is a face-to-face assessment, and that was really important. It also helps to help family members get connected to the system. What we know is a very large percentage of our callers whose child is in a crisis haven't yet entered into the behavioral health system, so it's very important. That face-to-face connection really gives us a much more thorough intervention. We do overcome access barriers, again, particularly for populations who are sometimes underserved. Our proportionality rates are very, very good and reflect our population. And it is not, we don't see it as only a response for the community, but we see it rather for the family, but we also see it as a quality life and an important service for the family. So those of you who are familiar with Connecticut, Connecticut is small. If you go east to west by car, it's basically about a 2-hour drive. From north to south is basically about an hour. So we're small. Another number of you large states have counties that are as big or bigger than us. We have 3.5 million people, and we have about 800,000 children. So that's a little bit about our background. The red dots represent all of the areas that our 14 sites are located, and so the providers in particular in the northeast corner and the northwest corner had to be somewhat strategic about placing those, because they have to be able to get in the car the moment they hang up and be face-to-face within that 45-minute window. So there are a couple of areas in those two corners of the state that require them to get in the car and start traveling very rapidly. Connecticut, although small, we do have large urban centers, we have a lot of suburban areas, and we do have the rural areas also. So what are the available services? We do provide the response in home, school, and in the community, and in particular we also go right into the emergency department and we'll do assessments there. Some of emergency departments allow us to do that assessment before, quote, fully entering into the ED, and we're getting more responses following their quick assessments to do follow-outs or offer families appointments as they leave the emergency department, and we'll often meet face-to-face with them while they're there. We do crisis stabilization. It's really stabilizing that acute phase. And then we also do the follow-up and connect them more deeply to the system. We really do advertise quite a bit and encourage mobile crisis as an alternative to sending kids to the emergency department. We also encourage law enforcement in schools to use it before making any decisions to call an ambulance. We do, as I said earlier, we do use a statewide clinical assessment that all of the providers use, and we do have a number of additional assessment tools that for substance use, violence, sexual abuse, and those they can use as needed, and there are others, a few others that they also have access to if they need to. They can keep the episode of care open up to 45 days, but that's really a benchmark for providers because families can call anytime they want. The 45-day window is that the provider just needs to close out that paperwork or that clinical assessment during that 45-day window. Families who call have access to a full psychiatric evaluation, and the providers hold appointments for them as needed, and they also do medication management. We also emphasize quite a bit collaboration with families, schools, and hospitals, in particular making sure people have information about what happened following the mobile response. And again, information, referral and linkage to long-term, more appropriate services is one of our strong focuses. We do have a standardized training component. There's 4 modules that we require within the first year and are kind of our baseline. It's the crisis assessment planning intervention, trauma-informed care, emergency certificate training. We do have the ability to do an emergency certificate for children if necessary, and then a violence risk assessment. So that's up front in that first year. And then we have an additional training that are core modules that the providers are required to do within the second year. And we do offer all of these the core modules are offered 4 times a year at various times throughout the state, and the other additional core modules are offered 3 times a year. We also had to make a decision. We will do a training with as few people as 6 or 7, and we had to go down that small because you do need to really flex the opportunity because people have to be responding. And there you can see the other list of training modules. We do think it's important that our suicide prevention folks are well connected to mobile and vice versa, and we see and bill the mobile clinicians as the experts in the community to do suicide assessments, and they do quite a bit of suicide assessments. And the other piece is we are also very connected to our disaster behavioral health response network, which is really in times of need, it's really important for our system to be aware of that. There are the other topics you can read there yourselves. So here's a breakdown of all the calls we get annually. About 22% of those are phone only. So frequently caregivers will call and just say, for example, I've had a very rough day. My child was in a crisis. This is how I handle it. I just want to check in with somebody, so they have a master's level clinician who they can just do the phone only with. About 44% of the time we are doing those face-to-face assessments, and those about 44% of the time those are 5 days or less. And then over 5 days is about 34. We chose 5 days because what we refer to as sometimes one and done. You can see the mobile crisis clinician can see the family as many times as needed between 1 and 5 days, and they just have to do the statewide assessment. It's a little bit shorter assessment tool, but the moment that episode of care goes beyond 5 days, they have to do a little bit more paperwork with a more comprehensive assessment. And primarily those that go beyond the 5 days are those who need linkage to longer-term, more appropriate care. Many of the 1 to 5 days already are connected to care, or for some reason aren't showing a need for that. So that's a little bit of our data. This data did flip-flop. For a number of years, we were about 34% of the time we were face-to-face 1 to 5 days, and 44% of the time the families went beyond 5 days. And as volume continued to increase, we saw that flip-flop a little bit there. But the phone only has stayed around the same. So the way we staff, we mentioned this before. Basically, the only new piece here is to share with you that our mobile crisis teams all are housed within the 6 organizations that they're housed, have a large full service array internally. So many of these families who are in need get connected directly to intensive in-home. Connecticut has a very robust evidence-based practice array of intensive in-home services. We have outpatient, we have intensive outpatient treatment, we have care coordination, and it's connected directly to our care coordinators who do the intensive wraparound. All 6 of our providers are also care coordinator agencies. So they have direct linkages to a number of referral sources, and also frequently can jump waiting lists if necessary or if they deem that appropriate. But when they don't have those services in-house, they are also very well connected and have good ongoing relationship with providers, other providers who have other services in the service array. So a little bit of our data. This is a result of good data over what is now over 10 years. So this is just last year's, and so you'll see there this is almost 10,000 kids. But essentially, for 9 to 12-year-olds is about 26% of the kids. 13 to 15-year-olds about 33%, and 16 to 18-year-old is 23%. So our largest population is that 13 to 15 age group. And if you go 9 to 18, that's over 83%. Racial background, as I said earlier, we have a good mix, and this is pretty well proportional to Connecticut's needs. Our Connecticut's average is about 19% Black or African American, so we serve a little bit more there, and Caucasian is a little bit reflective of that. The Spanish-speaking or Hispanic, 32%, almost 33% are Hispanic origin or bilingual. We have a very large number of bilingual master's level trained clinicians, so we do a decent job in getting bilingual services. We also have a variety of clinicians who are bilingual in a handful of other languages around the state. This is health insurance status. Basically, 63% of our population we serve are Medicaid, and about 30% are private insurance, and the majority of those private insurance carriers now also reimburse the service. Here's a little bit about our presenting problems. You'll see that the highest ones are suicidal ideation or risk of harm or harm to self or others, disruptive behavior. Again, boys tend to act out, girls tend to act in a little bit more, and then depression. So those are the three highest. We do track all that, and we have much more individualized data if we needed to, but I'm just giving you some of the high points. We have a very high rate. Over 61% of the kids that we serve have been exposed to trauma, and in some communities it's much higher, and the number of trauma exposures that they have are actually multiple, and we have individualized data on the types of traumas they've been exposed to. This is a breakdown of our total calls. So last year we had over 18,000 calls. That would be that farthest for fiscal year 17. And of those 18,000 calls, 13,000, just under 13,500 were developed into an episode of care, which meant that it was a full open, it was not a phone only, and it developed into a full episode of care. This is a statewide mobility rate view, and just shows us that the benchmark of having to go be responsive 9 out of 10 times face-to-face. The goal is 90%, and this just shows you the progression over the years, and the statewide system is over 93% of the time they are face-to-face in that 45 minutes window. This just shows you a different view. This includes all the 6 regions, and then we also have it by all 14 sites. So each site also knows how well they're doing, and we always put the statewide benchmark in there so that they know exactly. We share all the data with all the providers all the time. It's fully transparent. This is response times under 45 minutes, and again, the benchmark here is 80% of the time they need to be 45 minutes or less, and these are the rates. And again, most of the time, the statewide median last year was, as I said earlier, 27 minutes, so they're doing a good job hitting that benchmark. This is just, again, another view of that, broken down by each of the 6 service categories. And again, if the sites, most of the service categories have 2 or 3 sites, and they could see these rates by site. So if you have a satellite that's in a far rural corner, that would have a lower rate, and then the part of their system that's in the city, they may have higher rates. So we could actually look at this data by individual sites also, so they're able to see that routinely. This is our outcome measure. We use the Ohio scales, and we've used this for a number of years, and it continues to show that our outcomes are really good. Both the parent report, the work report, and when we get the child report, there is statistical, clinically meaningful change both in improvement, functioning improvement, and problem severity reduction. And we've seen that, sustained that over a number of years. Cost is always really important, and you want to be able to justify and show cost savings. So we do a lot on making sure we show our cost savings, and we developed a formula for that. So we'll just click through that and show you how we developed the formula to make sure we can make the argument for how mobile crisis is saving dollars in the overall system. And we also point to other resources as well. You'll need as much information as you can gather on this, and no single way is perfect, but if you do multiple shows of how you save dollars, you can make a stronger case. So our average inpatient in Connecticut for last year was just under $12,000, $11,000, or just under $11,500, and our average mobile crisis response was just under $800. So if you take that as your base formula, then we calculate this figure conservatively by utilizing data that the emergency department staff code directly themselves, and they say they refer directly to mobile crisis in order to divert this child to an inpatient referral. So that happened 449 times. And so if you just take the percentage of those 449 who are Medicaid, which was 278, and you multiply that by the cost savings, the difference between those two previous figures, we get an almost $3 million savings last year alone in savings from expenditures. So that's one way. Again, if we don't have access to the commercial insurance dollars, but we continue to add to this picture. But essentially, you need some metrics to try to demonstrate what you're saving. So what are the lessons learned in Connecticut? One is we really developed contracts that were very clear model and based off of many of the lessons learned, and we're very clear in terms of what our specifications and what our performance expectations were. Developing those benchmarks over a number of years was really, really important. The just go mentality and the crisis defined by the caller is probably the single number one cultural shift that we made among the providers, and that we're buying face-to-face assessments. We're not buying any time to sit on the phone and kind of try to triage whether this is an important call or not. So that's probably the largest single change that we went through. A single-wide statewide call center is really, really important. What we learned prior, we had over 12 different numbers, and what each of those providers were telling us they were capable of doing, we learned they actually were not able to do after the fact, and we learned that through a variety of means. But a lot of the times they were unable to do multiple calls. They just don't have the capacity to be an effective call center. So that was a really important. Standardizing the practice model and developing the best practice guide was really important. Promoting access and quality outcomes, again, using data routinely, being fully transparent with all the data. We showed on 2 websites routinely, and it goes out monthly, quarterly, and annually, and they all look forward to that. And we talk about, there's a data, we meet monthly with all the managers, and half of that meeting is dedicated to looking at data and any practice issues. So we're constantly doing kind of these data assessments and focusing on a particular issue. We really drive the important message that utilizing mobile crisis is a much better alternative to sending kids to the emergency department where they may be traumatized again by things they see there. Also, we do a heavy amount of outreach activities to law enforcement in schools and the EDs. And we just think it's really important that they're well funded and they can be responsive to the need. So my contact information is there, and our project coordinator is also there. So any other questions or?
Yeah, thank you, Liz and Tim. Both of these presentations were fantastic, and the chat box has been very active, so there are a number of questions that I hope we can get at, and many of them are for both of you. One question was, Can you talk a little bit about a single point of access approach and how that fits with the no wrong door approach that that's used in some areas?
Liz, do you want to go first?
Sure. So the concept in New Jersey was that one phone number for all families, and it doesn't matter, who sent you there. So it really is no wrong door. And recently in New Jersey there was a challenge because there's of the opiate epidemic in New Jersey. There's another call line for NJ Reach, it's called, for folks to call to get specific services around the opioid epidemic. And for them, it's still no wrong door. If you connect to any other line, any other call center in New Jersey, they connect to perform care if there is a service or support that the youth or family needs, and it's done through a warm handoff. So there's absolutely, complete access was the goal. One number for all families to call 24 hours a day, 7 days a week. And there's a connect to all the services and supports that are necessary. And if we don't have it, if the Children's System of Care doesn't have it, then they connect to whoever does. That's how New Jersey manages.
So for Connecticut, the mobile crisis in particular is a single point of access through that 2-on-1 system. And again, the prompts of additional 2 ones, 1-1. We have an administrative service organization that manages our Medicaid behavioral health, in particular the high-intensity areas like ED, inpatient, outpatient, intensive outpatient, those kinds of services. We're not a fully closed system of care system. So, but what becomes important, but for all those others, you have to call. Beacon Health Options is our administrative service organization, and so you have to call for approval for any of those high-need ones for Medicaid. And mobile crisis, in a sense, becomes a single point of access because we know so many of the families that use that, a large percentage of those, or a large number of those, I should say, are experiencing the system for the first time. So it is a gateway in, but we don't have a fully integrated system in Connecticut.
Okay, great, thank you. There are 2 questions actually that get at the concept of potentially very short-term out-of-home stabilization. One was about whether either of you have short-term crisis beds, if a youth needs that after a mobile crisis assessment. Liz, you mentioned that there is the availability of out-of-home placements as needed that's not accessed directly through mobile crisis. So what happens if a crisis stabilization bed or some kind of out-of-home stabilization is needed?
Yeah, for Connecticut, whoops.
Go ahead.
So
Go
Connecticut,
ahead,
we have crisis respite and crisis stabilization. It's a 1 to 14 day, and the gatekeeper is the mobile crisis team. So you can't get in unless you've had mobile crisis out, and then mobile crisis helps to facilitate the referral in. Depending on the situation, there may also need to be a call to Beacon Health Options for approval, but generally, again, that's done through the mobile clinician rather than the family. So we have 70 beds statewide that anyone in the state of Connecticut to access for either crisis respite or crisis stabilization.
Okay. Liz, you want to take that?
Yeah, absolutely. So, there are 2 components that are important. So the first is that for our youth on the behavioral health side of our house, which is the longest standing work in New Jersey, there's no connect to respite beds, nor is there a need. I was there for 5 years, never received a request from a mobile response call for an individual with a behavioral health need for a crisis respite bed. All of the youth who require some out-of-home, which is a very contemplative sort of process within the context of the work in New Jersey, that happens through the care management organization, but I never had a request or need. Because the use of mobile response is 2 steps before that youth is in a really high intense crisis. And so I think it's just really important to know that the work has shifted dramatically in New Jersey. So you're talking now about a parent who's feeling overwhelmed because their child won't go to school, but it's the beginning part of when they are experiencing crisis and not at that moment where you go, you have to get them out of here. But what's important is in 2012, when we integrated youth with intellectual and developmental disabilities, that discussion changed dramatically for the children's system of care because we were now at a crisis point with youth with intellectual and developmental disabilities, and we built crisis stabilization beds for initially for the 18, well, it's really 16 to 21-year-old population, and that was the highest need at the time. And then we built 15 beds for 6 to 10-year-olds because they were the second largest request for 6 to 10-year-olds for youth with intellectual and developmental disabilities. But what's important is by the time we opened those beds, because we had to go through an active bidding process, and we had to actually, construct these 5-bed group homes in the community. By the time we actually were ready to go live with them, we had no 6 to 10-year-olds to put in them because all the 6 to 10-year-olds were receiving in-home supports and services, and mobile and our community partners were able to stabilize them. So I think it's important to understand the role of crisis beds in your system, and the earlier you get to the table for families and the more preventative in nature you are, the less likely it is that you'll need those.
Okay, great.
That's just New Jersey's experience.
Great. Hey, Beth, this is Denise. I just want to do a time check because this is fabulous. We're getting a lot of questions coming in, and we only have 8 minutes left. I don't know, Institute staff, if we should stay on the line, offer to stay on the line longer. If not, I don't know what we have bumped up against this. If not, we could always post the responses to the questions we don't get to and send that out along with the recording to this webinar.
Great. So maybe we should just see what we can get through in the next 5 minutes and then take it from there.
We can do that. I also want to remind folks or ask folks to please stay on the line and respond to a survey that we'll have at the end of this webinar. This provides us the opportunity to get your feedback and also helps shape next efforts as well. So please do stay on and give us your feedback. Thank you. Go ahead, Liz. Beth, sorry.
Okay. One question is around reimbursements. Tim, you mentioned that commercial insurers are covering MRSS, and I'm curious as to how you work with them to get them to cover this service. It's not something that typically they would.
Well, so what we did, we actually took a tip from New Jersey actually on this one. We just provided it, and Medicaid was reimbursing, and we just encouraged our providers to continue to bill Medicaid, and our fair billing practices requires us to also bill any private insurance. However, the families never see a bill. If the families see a bill, it becomes really problematic because then they feel like even if you tell them that it's free, they don't use it because they worry that they're going to be charged. But essentially, we kept going back to the commercial insurers and showing them the data and demonstrating the success. And they always said they covered it, but in some areas they would pay for it, the same plan. In some areas of the state would they pay for it, in other areas they wouldn't, to the point where they now pay routinely, and the providers rarely talk about problems with collections from the commercially insured. So I think it's one of those situations where success breeds more success.
Right. Okay, I think we have time for one more. There are 2 questions that relate to providers. One is around whether you have difficulty keeping and recruiting staff for these crisis positions.
In Connecticut, we do an annual meeting and every year, and we celebrate the success. We show them their data. They get a little a luncheon, and we do that twice, and we give them back, and we we ask every single year, like, how many people, and what we've learned is about 50% of the time the clinicians turn over in the first 2 years. If you make it past the first 2 years, it's pretty stable. The number of folks that we have 5 years and beyond is just really amazing. And I would say at every annual meeting, there's somewhere around 20 to 25% who have just joined in the last year, but frequently about that same amount who've also been between 1 and 2 years. So nationally, I think the data around any of the intensive in-home models, and I think mobile crisis in Connecticut follows that, it's about a 50% turnover rate every 2 years.
And what do providers do when they're not on a crisis call? And then, Liz, maybe you can respond to both of those briefly, too.
I'm sorry, the question was, what do supervisors do?
What are the providers, what are the crisis workers doing when they're not out on crisis calls?
Oh, there's just a ton of paperwork on the assessment. So okay. they'll get the acute crisis and they'll get the basic paperwork, but there's a lot to be done. In fact, to the point where if they go out back to back to back to back, the manager will need to pull them and have protected time so they could actually complete all their documentation that they need to do. Great.
Okay. And Liz, do you want to respond for a minute about the recruitment and retention issue?
Sure. So recruitment hasn't historically been an issue, but New Jersey utilizes bachelor's level for frontline, for the crisis, the actual response, and then they supervise with licensed practitioners, which are a little more complicated to keep up and keep staff. But like Connecticut, New Jersey has had a long history with some folks really being engaged with mobile response for a very long period of time. So we've had a lot of stability in the staffing. And then in terms of what do, they do a lot of different things. That's a lot of the stabilization time that happens. So when they're out on crisis calls, there's the follow-up of the stabilization components and connecting youth to the community. So there's a lot of work that gets done in terms of that component. New Jersey's electronic record allows them to document anywhere that they are because it's a web-based program that they can document their work in, but they need to make sure youth are connected to the community and in long-term sustainable plans.
Great, thank you. We have 2 more minutes to go. If we can have just like a very tight response to the question about whether you're aware of mobile response and stabilization services that involve peer providers, either as part of the crisis team or referrals following crisis services.
Yes, in Connecticut, 2 of our 6 providers use them. In our contracts, we made that available option, and most of the time what they're used for is the crisis stabilization part of the intervention. So after the acute crisis is over and there's looking for linkage, the peer support partner goes out and helps with the long-term linkage to a better service long-term.
Okay, great.
And in New Jersey, there is a connect to the family support organizations that provide both support for youth. There's a youth partnership work that's peer support, and with parent and peer support that allows parents to participate in both support groups as well as educational opportunities. And there's a direct peer-to-peer support for in some specific situations.
Okay. Thank you. There are a few questions we didn't get to, and we do have those, and when we send out the recording, we will make sure that the presenters are able to respond to those remaining questions that we didn't have time to deal with on the call. I really would like to thank our presenters for their great work on this and for the very rich information that was shared. I think there are so many practical strategies that you provided. I think you participants will find useful in your states and communities, and in particular what you as leaders need to think about as you're planning and building this capacity. Thank you also to Tiara Brown from the TA Network, who handled all of our technical needs during this session. And again, thanks to all of you for joining us today. was a great and very involved group. We love to see that. Reminder that the next Learning Community meeting is on February 22nd, current issues for working with family and youth organizations. And again, the survey will pop up afterwards, and we certainly appreciate your taking that. Thank you so much, and we hope to